And maybe just while we wait for more people to join, I'll go ahead and thank you guys for joining Dr. Vogel and I today. For those of you who don't know me, you maybe just joined the group, the Menopause Support ATL group today, and don't know me, I am a physical therapist here in Atlanta. I work in Buckhead at Inspire Health. I just wanted to change the view, the speaker. Okay. I work here in Atlanta at Inspire Health. I'm a physical therapist. I by no means am a menopause specialist, but it's become a area of very big interest for me as I started going through perimenopause myself. And as I started to do some research and dig my heels in, I found kind of a lack of information and a lack of support from providers. So I wanted to create this group as a way to make sure women were getting the education and the knowledge they needed to help seek the care that they may need. So that was the impetus behind setting up this group. And I like to keep it active, bringing in speakers like today. So, and Dr. Vogel, thank you so much for joining us today. You're definitely one of the areas, if not nationwide, one of the leading menopause specialists. So I feel incredibly grateful to have you want to give a talk for us today. So tell us more about yourself.
Well, thank you for the ramp up. First of all, this is something that I really enjoy. Doctor in Latin means teacher, and one of the best parts of my medical practice is just teaching people. And when we're talking about perimenopause, menopause, and all the changes that can occur, it really is educating women about the kinds of changes to expect in their body. And that's a lot of fun. So this is, I wasn't going to use PowerPoint. I was just kind of going to talk. Plus I had a big sign made that I was going to point at. And then this afternoon, when I started kind of putting things together, I thought, well, you know what? I think it would be useful to bring some slides in. So this is a little bit last minute, but I don't want you to feel at any point that this is, like you're back in school, or that this is a formal environment. I want this, first of all, this is not for me, this is for you. And the goal is at the end of this talk today, that you have more information and that you're better informed. And hopefully, that makes you a better medical consumer, but it also gives you comfort in knowing what to expect and what options you might have. So I will launch into a little bit of introduction. How did I get interested in this? I kind of fell down the rabbit hole of menopause, perimenopause when I was a second year medical student, and got very interested in it to the point that as soon as I got my license, when I was a resident at Emory, I decided to open up a menopause clinic. And I did that as a full-time thing for about 7 or 8 years, until circumstances led to me moving from the Army National Guard to the active duty Army, which I did for 17 years. After I closed my private practice in Atlanta. And during that time, I did a lot of different things, but I always kind of kept my finger in the menopause world, because it's really academically and otherwise, it's kind of my first love in medicine. In 2013, excuse me, went back to school and I did a fellowship in interventional pain management. And so I kind of wear two hats now. I'm a pain specialist, but I still work in the menopause arena, and I've largely combined them such that my practice is mostly chronic pelvic and sexual pain. And then I also do kind of what you might call regular old menopause, perimenopause consults.
Awesome.
All right, so I'm going to launch into things, and we're going to look at this first slide, which is, if you're not familiar with it, it looks kind of dizzying. So we'll just kind of start at the top. You can kind of look at this later since it's recorded, but this runs from the period of a woman's first menstrual period until her final menstrual period. So the reproductive life is broken down into reproductive,
Mhm.
menopausal transition, which is just another word for perimenopause, and then postmenopause. So I put some red stars around perimenopause because that's going to be what we're going to focus on today. And
Yes,
now if I can get this slide to move.
You want to write on water? Okay, just go get a piece of paper.
got it.
I didn't hear that, but I guess we move on. So we're going to zero in and look at the perimenopause, and it's not one thing. It's a process, and that process is different for every woman.
Mhm.
And the period of time, the speed at which it occurs, the changes occur, and the total amount of time that women are in this transition period varies a lot.
Mhm.
I put a red circle around change in experience. It sounds like kind of a vague thing, and it is, because this is, and the one of the things that women talk about is frustration in not, they know that something's different in their body and they think it's related to endocrine changes, but there's nothing else going on gynecologic. Their periods are still marching forward with regularity. There's no change in their bleeding pattern. And unfortunately, too many times when they ask their medical professional about it, they are told, no, it can't be that because you're still regular. And that's just not true.
Not
So
true.
that's what this change in experience is. As you kind of look over a little bit to the right, once periods become irregular and
Mhm.
skipped periods start occurring, it's kind of obvious to everybody, oh, okay, you're perimenopausal.
Mhm.
That doesn't mean, and this is a really important thing, that doesn't mean that some really important symptoms can't occur quite a bit before that. You can see that's a 2 to 5 year period. And
Right.
if you add up this whole transition, you're looking at about 5 to 8 years
Mhm.
of transition. Again, the beginning phases may be very subtle and may not be noticed, but they are still occurring and still occurring. And it's really related to the ovaries getting older and changing the way that they work.
Yes. Yeah, change in experience I do think is to be highlighted because for everybody it feels different, correct? And you don't feel you're the same, whether it be physically or mentally. Something's different.
Right. And it's important, that we understand, everybody kind of understands that reproductive hormones do way more than work in the reproductive
Mhm.
track involved with reproduction. Bone, muscle, fat, the heart, the brain, the
Mhm.
lung, they are all hormone responsive tissues.
Mhm.
That doesn't mean that all of those organs will manifest symptoms. And when we talk about change in experience, the by far the most common changes that occur in the absence of any changes in the menstrual cycle
Mhm.
are in the central nervous system,
Mhm.
which is um, quite an important target for estrogen and progesterone.
Mhm.
So we'll kind of come back to that.
Right.
Um, some of the things, some of the things that can be impacted, particularly mood. One of
Mhm.
the common things is a woman will say, everything's going great in my life, but I have this free floating anxiety that's just kind of come out of nowhere. I've never had it in my life. Probably number one.
Mhm.
Periods of depression during the cycle. Women who have headaches can notice a change in the pattern of their headaches that they've had their whole life.
Mhm.
That has to do with variability of the amount of estrogen that's being produced during the cycle.
Right. And this
Okay.
is what correlates with a lot of women being given the talk about antidepressants.
Hi. Yes, it does.
Mhm.
And interestingly, um, one of the specialties I get referrals from are the psychiatry.
Mhm.
And the conversation goes like this. Hey, I'm seeing this lady. She's in her early 40s. everything's great in her life, but she has these new mood changes, and it's not organic. I know it's not organic depression, but I don't know what to do about it.
Mhm.
Or maybe they'll say, I'm pretty sure that it's hormonally related, but I don't know what to do about it. So that's at least a validation that it's not something that has to be treated with antidepressants per se, and maybe not the best way.
Mhm.
Okay. I think it's important to have kind of a little bit of baseline knowledge before we talk about the changes that occur.
Mhm.
Let's talk a little bit about how, what happens every month. So we're going to start over at the 9 o'clock position, and we're going to work counterclockwise. So at the beginning of the month, actually, even as menstrual bleeding is occurring, the primary follicles are being recruited, and they grow and form follicular cells. And eventually, one of the follicles is selected for ovulation, although every once in a while it's 2 or 3. That's how we get natural twins and triplets, but it's quite rare. Then the follicle is expelled, also called ovulation,
Mhm.
and that marks the way that we separate the menstrual cycle from the follicular phase
Mhm.
to what happens afterwards, which we call the luteal phase. So now we're up around the 1 o'clock position, and we see the empty follicle. As soon as the egg is, excuse me, yes, as soon as the egg is expelled from the ovary, that empty follicle forms what's called the corpus luteum, but that we see at the 12 o'clock position. That structure produces progesterone that causes the lining of the uterus to stop thickening and
Mhm.
start ripening and preparing for pregnancy. If after, on average, 10 to 11 days, there is no implantation, which allows the corpus luteum to be maintained, then over at the 11 o'clock position, the corpus luteum regresses. When it regresses, it stops producing progesterone,
Mhm.
estrogen drops as well,
Mhm.
and a new cycle begins. So hopefully that's not entirely unfamiliar to everybody.
No, no, it's been a little while, but yes.
Oh, okay. Please don't let your eyes glaze over, because I
No,
put up,
I think it's
because I
great
put up,
that you're going through the background first. Appreciate it.
okay. This was to me, this is one of the most important studies that have been done in the world of menopause, perimenopause in the last 30 years. A very brave group of women volunteered to collect their urine every day for 6 months. So this represents all of the data that was gathered. So in the upper half of this graph, don't pay attention to the labels on the side or the numbers. The important thing is
Mhm.
that, and I put some red arrows where ovulation occurs. So it's kind of, it doesn't start at ovulation, it starts at the beginning of the cycle. And so the 0 day in all of these is the midpoint of the cycle, the
Okay,
place where ovulation occurs.
yes.
So there's 2 different groups of women that are depicted here. Women of, I think it's unfortunate that they maybe said normal. Let's say earlier reproductive age.
There you go.
Let's just for sake of argument, say there are women in their 20s who have very regular cycles. And
Mhm.
the open circles are the perimenopausal population.
Yes.
So in the upper half, we see LH and FSH.
Luteinizing hormone, follicle stimulating hormone.
Right. And because we're not all that smart, we name these hormones after what they do. So follicle stimulating hormone is what stimulates the follicle to develop in the early part of the cycle. And you can see there's even a spike around ovulation to give a little extra push. On the left-hand side, you see there's very little luteinizing hormone produced except around ovulation. So you can think of luteinizing hormone as the hormone that kicks the egg out the door. So it's only needed for a short period of time, and then it goes away. So what we see in both the luteinizing hormone and follicle stimulating hormone is that perimenopausal women make more.
Mm-hmm.
And that's because the ovary is getting tired. It wants to retire,
Mm.
but it's still got to work, another 5 to 8 years.
Mm-hmm.
So the brain, in response to that, a stubborn ovary starts producing, or I like to say, instead of talking to the ovary, it starts shouting at the ovary. Okay, get to work.
Yes.
Give me an egg.
Mm-hmm.
Okay. The other thing that's and that's really seen especially in the follicle stimulus in the upper right hand corner, where you see much higher levels of follicle stimulating hormone at every point in the cycle.
Mm-hmm.
That's biochemical evidence that the brain is really shouting at the ovaries.
Mm-hmm.
And even for luteinizing hormone, the peak levels are higher.
Mm-hmm.
Okay. What's the consequence of that? We say that in a lot of cases, because there's so much shouting going on, that the
Mhm.
ovaries become overly stimulated.
Mm-hmm.
And so that brings us down to the left-hand corner, where we see that at nearly all points throughout the menstrual cycle, E1 it stands for estrone, which is one particular estrogen. And we
Mm-hmm.
see that estrogen throughout the cycle is higher. So perimenopause, this is a really important takeaway point.
Mm-hmm.
Perimenopause is not a state of estrogen deficiency. It is a state of high estrogen
Okay.
and much greater variability.
I
You
see
see,
that.
you see the bars
Mm-hmm.
run through the circles.
Mm-hmm.
Here are the size of the bars in the younger women, where the variation is very small, versus the perimenopausal women where they're very high.
And this is what people have coined as the zone of chaos during the menopausal years, most likely. Yeah.
Yes, or I like to call it the hormonal roller coaster.
Yes.
So the highest outside of pregnancy, the highest estrogen levels a woman is going to experience is in the early perimenopause. And the human body does not like lots of big variations. It likes stability. Women's brains prefer to have relatively stable estrogen levels. A great example of that, many women, I don't know if it's most, but many women say the best I have ever felt, kind of mentally, energy point of view, cognitively, it was in the early part of my pregnancy.
Absolutely. Yeah.
You have very high estrogen levels there, higher than you'll ever see sort of during a regular menstrual cycle.
Okay.
Okay. But lots of variation, especially for women who have migraines and they're hormonally sensitive. That is to say, they regularly get headaches before their menstrual period and or around ovulation.
Yep.
These are women that have a harder time in the perimenopause, because all those fluctuations contribute to destabilizing the nervous system.
Okay.
Not good for a migraine
It's
patient.
not that they're having a sensitivity to estrogen, it's just a dramatic shift in estrogen going high or low,
It's the changes,
the changes and the
right?
frequent
That's why,
changes. Okay.
again, the most common influence of estrogen on migraine is premenstrually, when estrogen is high and then drops suddenly over a couple of days. So it's not, high estrogen is not a problem,
Yeah.
and low estrogen is not a problem, but going from high to low and
Okay.
back and forth from big variations, that's what the problem is.
Yeah. And just looking at these graphs, and you're going to get this later, but giving someone a low dose estrogen when they're going through this phase, it seems to be conflicting in my brain.
It is conflicting.
Yeah.
There is a way to use in certain populations, and women with migraine is one of these populations, to keep them from bottoming out with their estrogen. You're not going to change the high highs, but you can change the low lows by supplementing some transdermal estrogen at certain parts of their cycle. But generally, if you just throw that again, and it doesn't make sense. Wait a minute, if this is a period of the highest estrogen in a woman's reproductive lifespan, why do we add more estrogen? And you're right, it doesn't make sense unless, and I'm kind of getting ahead of things, but
I bet.
that's okay. One of the options to if you'll excuse my poetic sense here a little bit, or maybe lack thereof, if we say that the ovaries are getting cray-cray in perimenopause, one option that we'll talk about later is just take them offline. Get rid of all the variability, but we'll come back to that.
Yes.
All right. So we don't want to ignore progesterone. Progesterone, PDG, is a metabolite of progesterone that reflects the amount that's made. What we see is, and this is really one of the earliest changes in perimenopause, is the health of the corpus luteum each month starts to wane. And it doesn't make as much progesterone as it normally did when women were younger. And it oftentimes makes it for shorter periods of time. As women get older, then they can have follicle development, which creates estrogen and thickens the lining of the uterus, but then not ovulate. That's what results in missed cycles going 2 to 3 months. And then the natural consequence of that is once they do ovulate, they have multiple months of buildup of their uterine lining, and they have a massive period. Okay. There's no free lunch.
No.
Okay. All right. I'm going to segue from that. One of the things that I see that's done inappropriately is a lot of excessive use of laboratory evaluation. And I'm going to start off with the kind of 30,000-foot view that reflects my opinion about laboratory testing in general. This statement: physicians are prone to a standard of exactitude, which is not always reasonable, practical, or merciful. And the merciful should be with reference to people's pocketbooks.
Yeah.
Okay. So I don't want you to think that it's just John Vogel that feels this way about how laboratory testing should be used in the perimenopause and menopause. So I'm going to invoke some external authorities. So the first is, what does the CDC have to say about this? As in bold, you can see, as is usually the case for testosterone in women and children, and for estradiol in men, children, and postmenopausal women, we have difficulty measuring these things, and there's a lot of variability from lab to lab. And they're not just talking about serum testing, saliva testing or urine testing all kind of suffer from the same problems. Several of these hormones are present in very, very minute quantities, and even with our best equipment, they can be difficult to measure. But that's kind of a general statement about hormone testing that really doesn't necessarily bear completely on menopause or perimenopause.
Okay.
So these are a couple of very prominent menopause specialists in Europe. And I'm just going to kind of read these. It should be clearly stated that there are no published peer-reviewed data to show that a single or multiple salivary hormone assays accurately reflect the hormone status or needs of the woman. The screen, let me see if it's kind of blocking my screen a little bit. Let's see if I can drag that. There we go. And in particular, there's been no validation that they can be used to guide hormone regimens to give an appropriate hormonal response. Nonetheless, we see this very commonly done in communities. It has not been shown, and again, this is a kind of summarization of all the scientific evidence. It has not been shown that hormonal blood levels are useful in adjusting hormonal therapies, and salivary levels also have not correlated with clinical response. Here's the take-home message. Most experienced clinicians realize that hormone regimens are tailored by the clinical response. That means what you tell us, what the patient, what the woman tells us, and not by biochemistry reports.
Mhm.
Okay, so these are, when is there a time to do laboratory testing? And the answer is there are sometimes, but most of the time it's not useful. It doesn't help us determine what the right amount of hormone is, or what the optimal amount of hormone is. You'll see that used word, or that word used, excuse me. But there's no basis for making those statements. We just don't know what's optimal. And the truth is, optimal is not the same for any individual. So to use a particular laboratory number or range and call it optimal, that's just an untrue statement.
Yeah.
Okay.
And it's because there's so much variability that in
Very
the hormone levels, therefore it's not a reliable indicator.
It's not just that.
Mhm.
It's, we need to think about what's the most common reason that
Mhm.
that women use hormones. And this is really kind of more of the case in menopause.
Mhm.
They're using it for symptom improvement. They
Mhm.
use it for hot flashes, for night sweats, to help sleep, to alleviate their brain fog.
Mhm.
Women, each woman is the ultimate biological tool for measuring response.
Mhm.
There was a study done in 1999 using transdermal estrogen gel, where
Mhm.
they allowed women to, they said, here's some estrogen gel, go and adjust it, use as much as you think you need. Here's the parameters. You can
Mhm.
start with this much and you can go up to this much. And they said, then come back when you feel you have reached that place that is good for you.
Mhm.
And then they measure the estrogen level, and it was 47 to 48
Mhm.
picograms per milliliter. That is about what you get with a 0.05 patch.
Mhm.
If you look at the estrogen levels throughout a woman's cycle, and you just kind of average them together, because as we've seen before, they go up and they go down, but on average their blood level is about 80. So it's less than, or it's about half, or maybe 60%. So women are able to do that, and to try to superimpose laboratory normals on top of that when they haven't been validated to mean anything is, as I said, it's just unnecessary, and it's a waste of money. And particularly when those certain kinds of tests are out of pocket, that's really a disservice to the women.
Important.
Yes, and this very short sentence, less testing, more listening.
Mhm.
The story, perimenopause is a clinical diagnosis that you make by listening and putting all the pieces together,
Mhm.
and also understanding, yes, these changes can, maybe they don't start at 42, but there are women that are perimenopausal in their 30s.
Mhm.
It's there's a wide variation there.
Mhm.
So lastly, there are certain populations, there are women that have failure of their ovaries in their 20s, premature ovarian failure. That's a population where we're doing laboratory testing when you're way outside of when perimenopause should be occurring, when laboratory testing can be really important. Medical legal, for me, that is an issue surrounding testosterone, which has been covered in some of your previous talks. Just since I opened the can, I'll make another comment about it.
Please do.
So and this is another kind of illustration of things that people do that have no scientific basis. There's a woman in Australia named Susan Davis, who is the world expert in testosterone and sexuality. And she has done multiple studies to evaluate the question, does a woman's testosterone level predict the healthiness of her sexuality or her response to testosterone therapy? And the answer is no.
Interesting.
Okay. But I see it done all the time. Oh, your testosterone's low and this and that. You should, if I give you testosterone, you should get better. We can't say that. We can't say that. But I think it's a reasonable thing to do to get a base only for testosterone, to get a baseline measure, just to make sure you're not, that a woman is not already outside of, meaning above the normal range before giving testosterone.
Right. That seems important.
But they're all of these things are clinical trials where we put the tool in the woman's hand, give them some guidance on how to dose, and then work with them on, whatever feedback, whatever the results of the hormonal therapy is in their body.
Okay.
And clinical experience is what gives you that.
Mm-hmm.
Okay. So when Eleanor and I were talking a day or two ago, she said, you need to talk about the Dutch test because that's that women will be wanting to know about. And I talked about the limitations of laboratory testing before this for a reason. And this isn't even the complete test results, all the different things that they look for. You can measure a lot of things in blood, in serum, or in urine, but that doesn't mean that what you measure is clinically important. And this, to me, this is a really good example of that. And I look at this, and I'm a biochemist by background, so I love this kind of stuff. But the truth is that most practitioners held a party for themselves as soon as they finished biochemistry in medical school or PA school or nurse practitioner school, because it kicked their ass. They didn't like it. When you introduce a clinician to this much complexity in steroid hormone biochemistry, they're just not prepared to really understand it well and to implement it and to know what it means. And how that ends up is representatives from the company interpret the information for them.
Okay.
Meaning that's kind of like if I got all of my information about drugs from the pharmaceutical companies. So I won't say that there's nothing on here that isn't of value. There's one of the things that this test looks at is how estrogen is metabolized. And there's some data that how you metabolize estrogen has a bearing on cancer potential of the cervix, breast cancer, and squamous cancer of the head and neck. But when you're doing a snapshot like this, there's dietary factors that, particularly the consumption of cruciferous vegetables, that will skew this. So it's not necessarily a representative sample. And in my opinion, you would have to do genetic testing for the enzymes that determine how estrogen is metabolized.
Okay. So this is an example of someone's result to the Dutch test, not just one day of it, but what they would be given as a summary.
This is a summary report, and all I'm trying to do here is kind of show all the different hormones that they measure. And some of these, you can measure it, but there's no point. Because it doesn't give you, when I was an intern, I had a particularly difficult faculty member who was really ruthless. If we ordered tests, we had to be able to defend every test that we ordered. He said, tell me how every test that you ordered is going to change your clinical judgment and your clinical recommendations, because if not, then you've just wasted money.
Yeah.
And that's the issue that I have with these tests is it's not, if you think that this is going to change how you advise a woman, I think you're engaging in sophistry.
Yeah.
And the major medical societies agree with me, not just in the United States, but actually around the world.
Yeah.
All right. All right. I have some, I don't even remember now what I put for my backup slides. I think it was just a certain questions came up.
Mm-hmm.
You look real quick. Okay. Yeah, we're not gonna talk about these things today. We're not planning on it. No, I can't. Oh, there we go. Yeah. Okay. Actually, why don't I just get rid of that?
Yeah, this screen sharing, sure.
Yeah,
Oh,
if I can figure it out. Can see it on, oh, there we go. Stop share. Wonderful. Okay. Okay. So I'm done running my mouth. And let's do questions.
Okay, great. And um, if we have a few extra moments, though, you shared with me the other day during perimenopause that you think the use of the birth control pill can help alleviate a lot of a woman's symptoms. Maybe you could touch on treatment for symptoms of perimenopause per Dr. Vogel.
Okay. So there are some women that'll go through perimenopause with no significant issues. The same thing for menopause. And there are women whose lives are literally turned upside down.
Mm-hmm.
You know, perimenopause can hit at a very inconvenient time in life,
Mm-hmm.
at the peak of women's careers, when they just made it into the C-suite, and then things start falling apart, and they can't function at a high level. They typically, are oftentimes have children. Parents can be aging. They're trying to juggle a lot of different things, and they just don't need a disruption, a big disruption that's hormonally based. So I mean, I'm really kind of talking about situations that would cause a woman to seek medical advice.
Mm-hmm.
It could be something that's very narrow, like changes in bleeding pattern that are causing a lot of blood loss. So it could be the treatment could be very confined to that. Could be progesterone supplementation to treat the luteal phase defect, so that the endometrium has an opportunity to fully ripen and fully shut itself. An IUD might be appropriate in that situation if that's kind of if that's the only complaint that a woman has. But when things kind of come in, when complaints come in spades, and the menstrual cycle is really gone wacky, and there are central nervous system symptoms, mood, sleep problems. I referred earlier to if the ovaries are cray cray, that one of the things to do is just say, all right, I know you, it's like a worker who
Right.
comes to work, but their work is all terrible, and then somebody just has to come and do their job for them. So in that case, using contraception, or a contraceptive pill, and it could be a pill, could be a vaginal ring, it could be a contraceptive patch, something that has a strong enough amount of hormone that it just shuts down the communication between the brain and the ovaries. When there's a lot of problems, that a contraceptive method can solve a lot of problems all at once, and it really has a better ability to do that than any other treatment during this period of time, if there's a lot of different symptoms. Again, if it's just heavier bleeding, there's, that's not the only option. But when there's lots of things going on and that's really related to that crazy hormonal roller coaster, use of birth control pills for anywhere from 2 to 5 years is fine, is actually good. And it's kind of, I would say, it's my number one recommendation. Birth control pills, as long as a woman is a non-smoker
Yes.
and there's no other cardiovascular risk factors like uncontrolled blood pressure or crazy cholesterol or triglyceride abnormalities. There's no evidence of a woman continuing to use the kind of major societies feel up until 55. So if you want to ride that train, if you're happy with it, and a lot of women are, want to ride that train all the way into menopause, that's certainly an option.
Okay. And you probably are of the mindset that estrogen should be reserved till someone's postmenopausal, I'm guessing. And that causes that one day where you haven't had your period for 12 months, right? It's not a period of time, it's a set time. So there's no real benefit to doing a low dose unless, like we discussed earlier, someone's not tolerating the highs dropping to the lows rapidly.
So now we need to kind of transition talking about early perimenopause, and that's really what most of what we've been talking about, to now later perimenopause. And if you kind of go back to slide number 2, you can do that, but that's when menstrual periods start getting missed.
Okay.
Okay. Things are starting, we'll say the shutdown has begun.
Okay.
That shutdown process could be 6 months and it could be 4 years. That's when women typically start getting hot flashes, night sweats, because now you start to have prolonged periods where estrogen is low.
Yes. Okay.
Okay. And so it's actually things like using gels or patches. Late perimenopause is where that starts to become useful.
Yes. Okay. Wonderful. Maybe if you, only because this is something that you do, the ganglion block, that's for another talk. But if you could just briefly describe what that is it mainly for the use of hot flashes?
Hot flashes, night sweats.
Night
We call
sweats.
that vasomotor instability.
Okay.
The umbrella term. There are women who can't use oral contraceptives because they just don't get along with them. And then what do we do for women, for instance, who get diagnosed with breast cancer in their, during the perimenopausal period? They're on tamoxifen, or maybe they have already gone through 5 years of tamoxifen and their oncologist doesn't want them to use any estrogen, but they have ferocious hot flashes, which typically means that their sleep is terrible.
Yeah, for sure.
There are certainly medications, but what Eleanor is talking about is there's an injection, 2 injections into the neck, around nerves of the sympathetic nervous system. And we don't really understand why this is, but even calming that system down for a few hours using local anesthetic will markedly decrease or eliminate hot flashes for 4 to 6 months.
Wonderful. It sounds cool.
It's cool.
Maybe
It's a nice option for women who can't use anything else.
right. And that might include someone who is highly sensitive to the use of estrogen, right? And they most likely had a very rough first trimester with nausea and vomiting. Is there usually a correlation between how someone responds to their pregnancy and how someone's going to respond to treatment intervention of estrogen?
I would say if a woman has changes, symptoms during her cycle, just
Mhm.
associated with normal fluctuations in estrogen,
Mhm.
that's a woman who is hormonally sensitive.
Yes. Yeah. There's someone in our group that gets extremely nauseous. And when she's given estrogen, because she's hearing of the positive changes or the positivities of estrogen replacement postmenopausally, but she gets sick to her stomach and can't tolerate it. And I said to her, "How was your first trimester?" And it was awful. So it seems like a high sensitivity to hormones, one would surmise.
I would agree.
Yeah.
Women who have significant the condition that we call it is premenstrual dysphoric disorder
Hmm.
tend to have a more difficult, in general, tend to have a more difficult perimenopausal transition.
Right. Yes. All right. So how about we do open it up for questions?
Absolutely.
Absolutely. We still have plenty of people on, hopefully.
I didn't look in the
Yes.
chat just to see if there.
Yes. So we had, thank you for this discussion. Will you also be discussing postmenopause and hormone replacement options?
Kind of what Eleanor and I have, just a minute, I lost my camera. What
Mhm.
Eleanor and I talked about was there's more to talk about. And today's was kind of perimenopause.
Yes. So we'll do a phase two. And I just briefly looked at her question and I didn't see the postmenopause yet. Um, Someone said there, yes, they can agree their ovaries are definitely cray cray.
Okay. It's a little, it's a little dangerous for me as a man to call any woman's ovaries cray cray.
Yes.
So I hope that you're generous with your forgiveness on that term.
Yes. Um, yeah, so there's time for questions if anybody would like. Yes, here we go. Is a question. Does exercise help with symptoms?
I had a little outline, and I'm glad that question came out because it was something that I wanted to mention. And
Hmm.
the answer is yes.
Hmm.
And I want to be really clear that not all women, um, perimenopause and menopause are normal life transitions,
Hmm.
and they don't always need to be medicated. And lifestyle, and we have good evidence to say this, lifestyle helps our overall wellness throughout our lifespan. For some individuals who've been kind of cruising and not taking care of themselves, it can be an opportunity for them to reevaluate,
Hmm.
put in their mouth and
Hmm.
their activity levels and other aspects of their life, work-life balance, toxic individuals in their life that maybe they need to dismiss,
Hmm.
that
Yes.
all help overall, because we're talking about the health of the whole organism, the whole individual, both medically, psychologically, spiritually.
Hmm. It's very good advice. Yes. And as a PT, I would definitely promote exercise and resistance training because as we go deeper into our talks and approach menopause and postmenopause, bone health, um, and the changes
Totally,
in bone mineral density with the loss of estrogen. Yes.
totally agree. We've had evidence for 25, 30 years that
Very.
weight training for women as they get older is important, and the evidence just keeps piling up.
Yeah. Yeah.
Heavy as you can tolerate for
Yeah.
as long as you can tolerate.
Yes. Um, I don't see a question in the chat. Um, have you heard the term that's been coined, the musculoskeletal syndrome of menopause? Have you heard that term? Yeah.
Yes, I have.
Yeah.
So that's
Uh,
another that's
yeah.
another there's certain sort of I call them sneaky symptoms,
Uh-huh.
because that they can start to appear when nothing else seems to be going on.
Mhm.
And women that start complaining of widespread joint pain and muscle pain,
Mhm.
that's well known to be, and not always, because there's rheumatologic illnesses as well,
Mhm.
but it's a very common symptom of low estrogen.
Right.
Responds very well.
Okay. And yeah, and that's when I think of someone that's still cycling and they are having a lot of joints, aches and pains. Would it be appropriate to try an estrogen supplement or an estrogen treatment at that time
In
if
my
they
opinion,
don't try the birth control pill? Most people are like, actually, that birth control pill that you're promoting is make me cray cray. But I think they've gotten better over the years, but I do remember having a strong distaste for them personally.
that's understandable.
Yeah. Do you think the estrogen in a birth control pill, if that's the regimen of choice, would be helpful for joint related aches and pains?
Yes.
You do. Okay, wonderful. Yes. A few more questions popped up. We talked about exercise. I'm meeting with a doctor about my beginning tomorrow. Is there any advice you would say I should just say no to? Sorry, I read that very unclearly. I'm meeting with a doctor about perimenopause tomorrow. Is there any advice you would say I should say no to?
It's a little broad of a question to answer with much precision, not knowing what the reasons are that the individual is having the consultation.
Mm-hmm.
If it was bleeding,
Mm-hmm.
I probably if right out of the gate the
Mm-hmm.
recommendation was, well, let's just do a uterine ablation, uterine lining ablation, I would say no to that.
Yeah. Yep. And she lives in Denmark, so hopefully she won't be told you have to get these labs done today, or I'm not going to schedule a follow-up with you. Because like we talked about, the European standards for laboratory use, they're careful with it. Like,
Well, I'm pretty sure that Denmark has a single payer healthcare system. And so, there's no, to the best of my knowledge, there's no burden of cost on the individual patient.
yes. So hopefully that we answered that question. There we go. Correct.
Yeah,
No cost.
thank you, Paul. I saw a question, are supplements helpful? That's
Yes.
also, my first thought is, well, what supplements?
Mhm.
So there are supplements that are particular for, excuse me, for hot flashes. That's probably the most common things. And what's used that has some benefit is really, I don't know if you'd call them supplements. I would prefer to call them herbs. So the traditional things are black cohosh root,
Mhm.
and the rest of them, that's probably the one that's used the most common. And I'd say there are things that are in that realm that are helpful for mild to moderate hot flashes, but
Mhm.
they fare very poorly for somebody that has really severe vasomotor symptoms. So black cohosh root fits into that mild to moderate. There are a variety of different products that contain plant estrogens.
Mhm.
I'm not going to mention the names of any of them. Some of them are derived from red clover. Some of them are derived from soy. And those are safe, and those are for
Mhm.
somebody that really doesn't want to use estrogen,
Mhm.
a pharmaceutical estrogen, that is a reasonable option. I would just say have reasonable expectations that if you have severe symptoms, it's don't expect a lot of improvement.
That's good advice. Is Veoza's for hot flashes and night sweats, yes? And that's a pharmaceutical prescription, correct?
Correct. So
It's not hormonally based, it's just to treat those.
it It is a hormone, but it's not a sex hormone.
Okay. Okay.
So which for most people means they think of it as not a hormone. It works in a completely different
Mhm.
manner than sex hormones do, but it works in a part of the brain that controls the temperature regulatory system of the body.
Mhm.
So Veoza came out, it's about 2 years now that it's been out. And it's got a good safety record so far, and it's tolerated well. The worst part about that is its cash cost is about $560 a month, and
Wow.
getting it covered by insurance payers has been a challenge.
Mhm. Okay. All right. Anything that you want to make sure people take away from this talk? Well, wait, while we wait maybe for one or two more questions to trickle in, what would you say is your biggest takeaway for women that are um, moving into the perimenopausal stage?
I think my probably my first advice is, which is being done by being here, is be informed, be prepared. Um, if you are and if you are a woman in your 40s and you have a daughter,
Hmm.
teach them.
Hmm.
I can't tell you how many times I've heard from patients. Well, my mother never, yeah, I'd say, well, how was your mother's menopause? Did she, do you know when she went through menopause? I don't know. She never talked to me about it.
Yeah, I think that's a great piece of advice there.
We, yeah, mothers teach their daughters, about like to go through pregnancy, about what it's like to nurse and to raise children.
Hmm.
Make this a part of what you pass on to your daughter as well.
I love that. Thank you. You got a thumbs up for that one. Oh, we have a question from Laura. You can go ahead and
Hi, thank you so much. This has been great. Um, I was actually one of the ones that asked about the postmenopausal info, and the
Okay.
reason, so I have gone through menopause, and when I was in my mid 40s, I think I saw every doctor in Atlanta because I was having a lot of vaginal urinary issues, but I wasn't having anything else. I didn't have any hot flashes or, systemic anxiety, depression. And so I found that nobody could help me with these kind of local symptoms that I was having until I saw a functional medical provider, and she gave me a vaginal e-string, and it cleared everything up. And my question is, I've been using that literally for like the last, oh God, 6, 7 years, and that's all I've really needed. But my question is, like, I do get my hormones tested, and I'm like empty on everything, but I'm active. I lift weights. And it. Do I need to supplement with anything else as I'm getting older? You
Are you
know?
are you still menstruating?
Oh, no, 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 no.
Okay. You're menopausal.
Yeah.
Okay. Why are you getting your hormones tested?
Good question. After listening to you, I don't do it like,
I don't mean to put you on the spot. But you really brought up several things that I'd love to talk about,
yeah.
including the vaginal and urinary symptoms that you discussed. Um,
I mean, I
two,
get them tested when I go and I get my other blood work done. I get, my estrogen to, T1, and like it shows I have no testosterone. I have very low estrogen, but I don't take any additional hormone replacements. I did actually try to switch from the E string to the Fem ring to get
Mhm.
some more estrogen systemically, and I couldn't tolerate it. I got bad pelvic pain, and I mean, I probably didn't give it enough. It was like a week or two, but it just wasn't comfortable, and I went back to the E string, and everything kind of evened out again. So, you know, I'll be 54 next week, and I lift heavy weight, and but I've always wondered, is there any advantage if I don't have any other systemic symptoms, and it really seems to be more local related in terms of like vaginally, is there any reason to do anything else? And if so, at what point?
Really, really good questions.
I'm
Um,
sorry, before you answer it, what is the E-string, if for those of us that don't
I,
know?
I
Not
was
a
going,
vaginal cream.
I was going to clear that
Okay.
first for the people that are listening in. So E-string is, these are both silastic vaginal rings that are inserted and stay in place. The difference between them is an E-string puts out a very, very small amount of estrogen, just enough to mix in with the normal vaginal secretions. And so it's for vaginal and vulvar health only, low dose. The fem ring puts out a higher amount of estrogen to the degree that we would consider the muscles, the bones, the brain, all these other organs get a significant exposure to estrogen through the bloodstream.
Right. And I'll tell you the only reason I was going to change, and you might have some knowledge about this, I used to pay very little for the E-string. It used to be very accessible. And now it's up to like $500 every 3 months. And the fem ring, it's still like $100, $200, but it's been much easier to source according to the doctors. But I don't know if I should give it another try or what, but I just kind of went back to the E-string because I knew it, and it was predictable, and it seemed to be fine. But that was one of the reasons why I thought about trying the fem ring.
Okay, and economics are part of the whole decision process when you think about your options. So you like the ring. If you wanted a less expensive option, you could change to an estrogen vaginal cream. And
Which
it will,
I've tried.
yeah. Estrogen. When I first started out in the menopause business, a tube of estrogen vaginal cream was over $300, and now it's about 25.
Right.
And that will typically last a woman 2 months. So you're talking about $12 a month. So that's a significant savings, and only you can sort of balance out is the convenience of the ring,
Right. But
more
does the fem ring, the what you said about the fem ring, how it goes to the muscles and the bones, and is that an important aspect to
that
think
that
about?
gets,
If
that gets to that, when we change from talking about perimenopause to talking about menopause, we're really changing our discussion from talking about symptom management to talking about does a particular individual want to use estrogen now for preventive value,
right. Okay.
cardiovascular, bone health.
Mental health.
Yeah, mental health, the
Well, I
data,
guess,
the
yeah,
data,
the data's not there.
the data for estrogen there is weak to non-existent. So we can't say that's a benefit, but in multiple other domains, colon cancer, risk reduction is another one to kind of throw in there. That's kind of a long conversation.
Yeah.
My opinion is for most women, I think the risk benefit is to the positive
Right.
for estrogen use.
Right.
So my answer to you would be probably. It
Right.
doesn't have to be fem ring. You can use a different systemic hormone that you tolerate and still use your E-string just fine.
Okay.
But what you brought up was a great illustration of the sneaky symptoms
Mm-hmm.
that nobody recognized, because probably when it first started, you were still cycling fairly regularly.
Yeah. Yeah. I think I'm trying to remember. I mean, I think yes and no, but a lot of doctors wanted to say I had IC, interstitial cystitis, or get all these tests. I mean, I went to urologists. I went to, pelvic physical therapy. I went to, my GYN, and it it seemed so simple, but it wasn't.
How
So
many of them looked at your genitals?
all of them,
Did they? Hmm.
yes. And it wasn't until one, who's the functional one, said something, and she said, "I think we should try this."
And
And
like that was the right answer. We should try this because it's low hanging fruit.
yeah,
And some women, especially in late perimenopause, each tissue in the body kind of has its own estrogen requirements, and that
hmm,
doesn't just because the brain has enough that the vagina and urethra have enough. And estrogen is very important for their long-term health.
right. So yeah, it was interesting to me that I hear so many friends and telling me about all the hot flashes and the moods and everything, and somehow I skated by those, but it was that one issue for me that like really like knocked me out for like a year because it was just debilitating. So,
And for the people that are listening, when those kinds of changes are present, it increases your risk of having urinary tract infections.
okay,
Mhm.
interesting.
Got good
Well,
data.
thank you very much.
So really good example of a targeted solution for a narrow problem.
Mhm.
Right.
Thanks for sharing that with us.
Thank you. Appreciate it.
Good segue into there will be a part 2. Dr. Vogel, you'd be up for that so we can do like late peri to menopause?
I'm up for part 2 and part 3 and part 4.
Wonderful. Thank you for being so generous with your time and sharing your knowledge. Any other, I know it's been over an hour now. Any lingering questions, or I was just looking at the chat, don't see any additional questions. So maybe we'll just hold off to part 2.
Okay,
Thank you so much.
sounds
You're
good.
welcome, everybody. And thank you, Dr. Vogel.
Thank you.
My
Taking
pleasure. Had a
out of your
good time.
schedule. Yeah, it was fun. I look
Thank
forward to.
you.
Thank you. Thank you. All right. And for those of you that are interested, well, people are hanging out, but they can find you. The name of your clinic, it's Interventional Pain,
Innovative pain care.
Innovative Pain. Okay. And you're located in East Cobb area of Marietta?
Right.
Yes. And I hear your friends talking that they'd love for you to create more of a social media presence.
Yes, they've been on me.
Yes.
I've I've done 3 videos. I'm going to do a perimenopause video that I put up on YouTube.
Great. So when you post, it's on YouTube?
It is right now. I'm old, and so I
You
I
are.
post there instead of but I actually have an Instagram account, but I haven't used it.
Well, and you should be looking at all your friends making these posts.
I know.
Yeah, the Menoposse, I'd love to hear your impression of their how much information they're putting out, which I think is wonderful. It can only help, right?
Can I ask one more question?
Sure.
So when people do come to see you, is it, so you were saying more listening than testing. So is it basically, you know, kind of telling your story and then you coming up with a plan for whatever stage the person's in?
Yeah. So I'm going to use you as an example because I want
Okay.
to come back to this this testing and why. You said something to the effect of, I'm empty on everything.
Right.
And my answer to that is, duh. I can tell you every time that you go in, that you're going to be low because you're menopausal.
Right.
Your ovaries stopped making estrogen. There's no, oh gosh, that's a surprise. My estrogen is low. You stopped ovulating. So your progesterone that you do make you little factoid here. Outside of the ovaries, the adrenal glands do make progesterone, and then your central nervous system and your peripheral nervous system actually synthesizes progesterone, but it's small amounts. So if you do whatever, serum, saliva, urine testing, it's always going to be low. You know it beforehand. Why do you spend money finding out what you know already? Now let's talk about testosterone, because that's variable.
Mhm.
Okay. In an average woman. So if you're low, it just means you're low with reference to the normal range for women. But the next question should be, are there any changes that you've experienced that could be related to low testosterone? I had a patient yesterday who said, yeah, I'm having a hard time. I'm trying to get back in the gym, but I'm having a really hard time maintaining and building my muscle mass, wanting to do some weight training, which I absolutely think is a great idea. And I go into detailed questions about sexuality. Tell me about, how over the last, 10 years, how how is the level of spontaneous sexual interest? How is arousal? Are there any changes in your ability to have orgasm? If that's all great, why are you going to give testosterone? And why are you going to measure it? Because again, and this bears repeating multiple times, a testosterone level does not predict any of those things. You could be in the toilet for testosterone and feel great.
Mhm.
Now, estrogen's a little bit different story. You could still feel great, but there can be changes going on. For instance, accelerated bone loss that you can't feel. But you don't need to measure a level. And it does,
Recommend those bone density tests that they recommend?
at a certain, at a certain point, unless you have. So one of the things that I do in sort of, instead of doing a bunch of laboratory tests, is to do a deep dive into your medical history, your family history. So let's say you're a person that had rheumatoid arthritis and you've been using steroids to control your symptoms for the last 10 years. Then you need a bone density scan. If you haven't had it already at 54, you need one now.
Right.
It changes the equation for maintaining bone health, because you have used a drug for a long period of time that accelerates bone loss.
Gotcha.
So that's why I said the decision about whether to use estrogen postmenopausally as a preventive strategy hinges a lot on who you are as an individual medically.
Gotcha.